is injected into the pudendal nerve. Remember, it impacts a higher portion of the vagina than the local infiltration. So if you think about the words, the local infiltration is the local tissues of the perineum. The pudendal block extends higher. So when you use which one depends on how much of an area that you need to impact.
So it would be a laceration that would be like...
It depends on how much of an area you need to anesthetize. So there are different types of lacerations. We're going to talk about that. So it just depends on how much of an area that you need to, that needs to be treated.
Okay.
Okay. I can't remember. You had a second question. I don't remember what it was.
Yeah, I guess I was wondering when the opioids would...
Oh, you were asking about opioids. So it, again, it all depends. There's no way to give you these hard and fast rules because it's going to depend on what's happening with the mom. So the question was about opioids being given during labor. It depends on what's going on with the mom. It might be too late for her to get an epidural, but she still has a significant amount of pain. So that's a situation that could happen. And so the decision is to manage her pain with an opioid.
Would that be by the mother's request or would that be the team deciding?
It might depend. So what if you have a patient that for whatever reason is not is not saying that she needs pain management, but the team's assessment is the pain is interfering with the progress and the process, because pain can interfere with the process, right? So there needs to be a meeting of the minds. Certainly we're not going to just treat a patient with medication that they are absolutely refusing. So sometimes you have to have that conversation to let them know that this is going to help rather than hinder. But again, what is your primary concern when you're administering opioids to a patient? That's a question for all of you.
I thought it was the fetus, which is why I asked.
In general, any
respiratory
patient,
depression.
What is your concern? Your concern should be respiratory depression. Okay, what is the, when you give a medication, you give an opioid, when is the onset of action? How long are you anticipating? When are you anticipate? If you give a medication now at 9 o'clock, when are you checking the patient for peak action of the medication?
50 to 30 minutes, maybe?
So 15 to 30 minutes. You guys have to know this for all of your meds. So all of those meds that you covered in fundamentals, you have to know this because it impacts on your practice. So if you give a patient a medication, you need to know when to go back to check on the patient to make sure that it was effective or not, right? So you give a mom who's pregnant, you give her an opioid, you have to guesstimate. Now, we never know when these babies are coming, right? That's just the truth of the matter. We're doing our best to guesstimate when we expect the delivery to happen. However, if you think about it, if this mom is in labor and you are anticipating, let's see what time it is. Okay, it's 9:15. You're anticipating that she is going to deliver within, let's say you're anticipating she's going to deliver within the next 15 to 30 minutes. And she had an opioid at 9 o'clock. It has to be at the forefront of your mind, the possibility that this fetus might be born in respiratory depression.
Yes. Yes.
And what are you going to do about that? Okay, you don't wait until the fetus is out, until the baby is out and say, oh, the baby's not breathing. You have to always think about what is the situation and what might happen, right? So in that situation, what would you do?
Well, you said, well, it was said in the podcast to administer naloxone.
Even before that, what is the first thing you do? This patient received, and this is not just a question for Palomino, this is for all of you. The patient received morphine at an IM injection of morphine for pain at 9 a.m. It's now 9:15. You're anticipating this baby is going to be delivered in the next 15 to 20 minutes.
Mobilize the resuscitation team.
The NICU, you left everybody.
The first thing you're doing is calling your NICU team and telling them, I need somebody over here. You need somebody who can totally focus on resuscitating the baby. You will still have the mom to take care of. So you have to have somebody who can just focus on what's happening with the baby. That's your first thing. Okay, so certainly, yes, you make sure the resuscitation equipment is there, which it should be anytime there's a delivery, whether she's received an opioid or not. You don't know which baby's going to be born and just decide not to breathe, right? So your resuscitation equipment has to be ready, but make sure that you call in advance so you have assistance.
Yes.
Okay.
Another question about the administration of epidural. Are you waiting for the labor to be active? So we want to see a 6 centimeter dilation, or
You want the labor to be active, yes. So you want it not just to be in the active phase, but you want it to be active. You want it to be consistent. You want to see consistent contractions and progressive effacement and dilation. Because remember what type of medication you're giving with an epidural. It is, by definition, going to slow it down. So if the labor has not been established, and we're not advancing, and you give something to slow it down, we're not going anywhere. Where you're actually going is on your way to a cesarean.
Okay, thanks. Yeah.
That's where you're going, because that's what's going to happen.
Okay.
Okay. Okay, so what is your main concern with a patient who receives an epidural, a spinal, or a CSC? What is the main concern?
Hypotensive.
The postural ID.
Puncture.
So I heard,
Hypotensive? I don't know.
hypotension.
Yeah.
And so what do you, I couldn't find you because you're all spread out. Hypotension. And so what are your actions with that in mind?
We gotta constantly monitoring for blood pressure.
So even before you start monitoring, what are you doing?
Change positions, administer oxygen.
Even before that, your concern is hypotension, right? It's a neurological response to the procedure. What are you doing even before that? You know that this is more than likely going to happen. And so what is your proactive action?
The administration of fluids to keep the.
So you are
the blood volume.
preloading the patient with fluid to expand the vascular volume so that if the blood pressure does drop, it doesn't bottom out as much. Now, which patients do you have to be careful of when you're doing that?
Hypertension.
So your patients with hypertension, who else? Can you just give every patient a 500 milliliter bolus?
The bladder is distinct bladder, like, no, the bladder is full, so you can give them more.
Well, you would have them empty their bladder, but I want you to just think about this. What you're giving, you're administering fluids. So you, Jinhee, you said hypertension, but what about all of your other cardiac anomalies? What about all of your other cardiac issues?
Fluid overload.
Right? So your concern is fluid overload, but I'm asking you, what patients do you have to be careful about? So your cardiac patients, what other types of patients do you have to be concerned about with fluid overload? Not necessarily a diabetic. You might have it with a diabetic patient if if a diabetic patient has vascular involvement, yes. We're talking about fluid. I know it's Monday.
Water
As
retention.
renal dysfunction, your kidney patients, your renal patients, your patients with diminished kidney function, your patients that have any sort of renal issue. You can't just give them a bolus. Remember, anytime you're giving fluid in, the fluid's got to have somewhere to go and some way to get out, right? So you always want to make sure that there is kidney function. So if this is a patient that has a renal issue, you have to be mindful of that. Now, I'm not saying that you don't give it. There are ways around that. You might give a bolus instead of 500, you might give 300. So there are things that you need to do, but you have to start thinking about all of these different pieces. Okay? Because all of these are going to impact on whether or not you're giving, what you're giving, how the patient's going to tolerate it. Okay? All right, so let me share my screen and we will catch up with where we were with
Professor,
procedures.
I have one quick question. So it's about CBE class. What is the biofeedback?
So
Biofeedback. I don't know. Yes, because there was one of the class content, but I wasn't sure what is that.
so biofeedback
You have
is
to know.
it's one of the I'm trying to think of what the class is, of what we call this. So it's one means that you can use, and it's not just used in childbirth education, it's also used sometimes in mental health. I don't know if Professor Botanical covered it. Sometimes it's used for stress management and different, some of the anxiety disorders. But so basically what you're doing is using the feedback of the body to alter some of the responses. So let's say something as simple as how your breathing impacts your relaxation. That is a similarity to a biofeedback kind of a loop. Okay, how your breathing can impact your stress and relaxation. It's that type of thing. Okay. All right. So let me just get. Talked about the use of Pitocin. We talked about amniotomy. Just look at my notes. We talked about version. Okay, so here we are. All right.
Professor, can I ask you a quick question about version?
Sure.
I'm still a little bit confused when it comes to the difference between cephalic and version.
Between cephalic and version?
I mean, I guess cephalic is a type of version position, right?
No, cephalic is the position of the fetus. Version is the actual changing of the fetal position. Where's my camera?
Oh, I'm sorry. Okay, I was thinking of something else. Never mind me. I'm sorry.
Okay. Okay, so episiotomy and lacerations. So there is, I think I have episiotomy first. Okay. So I'll talk about episiotomy first, and then we'll talk about lacerations. So an episiotomy is a surgical incision. So it's a surgical incision that is done for a couple of different reasons. So to control the direction of the vaginal opening, if the tissues are not stretching and there's concern that they will tear, that they will lacerate, an episiotomy allows for control of that, that process. To support an operative vaginal birth, we'll talk about that in a few minutes. If there is a face presentation, remember that I said to you when we talked about positions and presentations that face presentation means the wider part of the fetal head is passing through the pelvis, and that will also be the wider part that needs to exit the vaginal opening. So an episiotomy increases that space. And to reduce pressure on the preterm fetal head. The blood vessels in the preterm fetal head are extremely fragile and are vulnerable to rupture. So performing an episiotomy reduces pressure on the preterm fetal head. The risks, of course, are infection, pain. The technique, there are two types, median and the midline. So this is the midline, is what it sounds like. The medial lateral is the incision that is a bit more off at an angle. Now there are pros and cons to each one. Pros and cons to each one. With the midline incision, the blood loss is a little bit less. The pain is a little bit less. The healing involves less scarring because of the dermatomes of the skin. On the other hand, a midline incision may extend into the anal sphincter. So again, think about the anatomy here. A medial lateral incision is not as likely to extend into the anal sphincter. A medial lateral incision actually enlarges the vaginal opening more than a midline episiotomy. However, with the medial lateral, the blood loss is increased. So there's more blood loss, and there's an increased likelihood of scarring. The medial lateral, because of the location of the incision and the way the tissues then heal, that tends to, healing of that incision tends to result in more discomfort for the patient, discomfort with healing and discomfort during sexual intercourse after the healing because of the scarring. Okay, so I think I posted this one for you that has, but anyway, the slides were pretty large so that you can see that. So during the third trimester, most moms are instructed to begin perineal massage to start to stretch and get the perineal tissues more loose and elastic. So perineal massage before delivery, certainly close to the time of delivery, and during labor helps with this gradual stretching of the perineum. So it reduces the need for an episiotomy, reduces the likelihood of a laceration. Delaying pushing until the urge is felt. So pushing again with the contraction so that the mom's efforts are in sync with what her body is doing. Pushing with an open glottis, not the hold your breath and push, but with an open glottis, that reduces the risk of needing an episiotomy or tissue laceration. Okay, So patient teaching. So before I even talk about patient teaching, you let's say you're on the postpartum floor and you're the postpartum nurse, and I'm giving you a report. I'm telling you that I'm sending you this patient that has a medial lateral episiotomy. She delivered at 6 a.m. What is part of your admission assessment for this patient? What has to be part of your admission assessment for this patient?
The read.
Reader scale.
Your reader scale has to be part of your admission assessment, yes. When you're doing your patient discharge, remember where this incision is. So in terms of your patient teaching, and remember, some of this is going to overlap with when we talk about lacerations, but remember the importance of making sure that you explain to the moms about diet, avoiding constipation, because you don't want a mom who has a healing episiotomy straining, okay? All right, so lacerations to the perineum. First degree, second degree, third degree, fourth degree. So first degree lacerations are fairly shallow. They involve the superficial vaginal mucosa, perineal skin. So usually these are repaired with a few sutures. Second degree lacerations, not uncommon. First degree and second degree lacerations are not uncommon. Second degree lacerations, again, repaired with sutures. These involve the vaginal mucosa, perineal skin, and deeper tissues. Third degree lacerations are much deeper and require a more detailed surgical repair. So sometimes you will have a mom, if she delivers and sustains third degree lacerations, she might have to go to the OR to have that laceration repaired. Okay, so these lacerations extend into and possibly through the anal sphincter. So this is a surgical repair. You should see some of your faces. This is a surgical repair. So if thinking about it makes you make that face and imagine what the patients feel like. So it's a surgical repair again. This is a surgical incision. So now you have a postpartum patient who is now a post-op patient. So again, your reader scale, all of your teaching around diet, because these patients, you definitely don't want them becoming constipated or straining, all right? So you have a surgical repair there. And of course, your fourth degree lacerations that extend through the anal sphincter into the rectal mucosa. So your third degree and fourth degree lacerations are surgical repairs, much increased risk. There's a much increased risk of infection, a lot of pain management issues, and they take months to heal, months to heal. So obviously we don't want these to happen. Again, it's one of the reasons for, as I said, an episiotomy, to control the direction of the vaginal opening so that this does not happen. There are a few other types of lacerations, periurethral. Those are lacerations in the area of the urinary urethra. These moms may go home with an indwelling urinary catheter. So they'll go home with their Foleys. Vaginal wall lacerations involve the mucosa of the vaginal walls, and cervical, which I have mentioned already. Remember that the cervix is very vascular, and lacerations can result in a significant amount of bleeding. So again, how are we determining the difference between bleeding from a laceration versus lochia?
The blood color.
So the blood color, what is the difference? The laceration, bleeding from laceration is going to be more
bright like
bright
red.
red, right? More bright red. And it also, sorry, whoops. It also bright red, and whereas leukemia has the cells and you might see small clots and mucus, the lacerations are going to be more like frank bleeding. All right. Let me just check the chat. Right. Okay, so perineal laceration and episiotomy repair. So I don't know how well you can see it, but the lacerations here, it looks like this mom had a laceration, a small laceration and an episiotomy, and this is after the repair. So this is before and this is after the repair. So questions about episiotomies or lacerations? So this is one of the, this can happen if, it's going to sound kind of roundabout, but remember how we talked about a mom with a full bladder who's unable to void, or possibly the mom who has an epidural, who has diminished sensation, and so a Foley is placed. If she starts pushing while that Foley is in place, that can contribute to a periurethral laceration forming. We don't really see these very often, periurethral. Usually if a laceration is going to be extensive, it usually extends posteriorly rather than anteriorly. But it can happen typically if a Foley is in place.
I have a question about that. I forget what it was called when you have the backup in the ureters going back towards the kidneys. What was that called again?
Reflux.
Right. And can the reflux pressure build up to enough to rupture the ureter at all?
No. Mm-mm.
Okay.
And that would be a little bit higher, but no, it wouldn't be from reflux. And I think that was Aminata. So regarding having a vaginal birth, are you speaking of with a periurethral? A mom that, Aminata, I just want to clarify your question. Are you speaking about after a periurethral laceration? I can't hear you. She might. It really depends on the extent of it. She might need a cesarean. So the question was, will the mom, after a periurethral laceration, will she be able to deliver vaginally with the subsequent pregnancy? She might not. The concern really is more about the urethra and damage to her urinary system, right? She might need a cesarean delivery, but the concern really would be more about long-standing, sustained damage to the urethra. Okay, so operative vaginal birth. Operative vaginal birth. Before I go any further, I want you to look at this name of this procedure, which I didn't name any of these procedures. So please don't complain. I mean, you can complain, but there's nothing I can do. The names are the names. That's how they were named. All right. When you look at this, you see nothing here about cesarean. I'm not talking about a cesarean delivery. We've already talked about cesarean birth. Operative vaginal birth, we're talking about two things. We're talking about forceps and vacuum. That's it. We're not talking about cesareans. We're talking about forceps and vacuum. Okay. And I'll talk about each of those in individually. So why might they be indicated? If the mom, you might have a mom that is exhausted. Maybe she hasn't been in labor a long time and she's just exhausted and she's no longer able to put out the energy that it's going to take to just complete this delivery. It might be that you have a mom that has cardiac or pulmonary disorder. And you have to be mindful of, remember, with labor contractions and with pushing, every time she does that, she's increasing her thoracic pressure, right? The pressure within the thoracic cavity. So if she has a cardiac issue, if she has a pulmonary issue, she might need help in stage 2. If for some reason she is unable to push effectively, it may be a comprehension issue. She doesn't quite understand what she needs to do. It may be a mental health issue. It may be something physical. So she may have a differing ability. And so maybe some of her muscles are not able to coordinate and push effectively. So to support her, that might be done. That kind of covers the fetus too. Now, this is not done if the if a cesarean delivery would have been preferable. So if early in the labor, if it looks like this mom is a better candidate for a cesarean, that really should be done, because it's really risky to go through a vaginal delivery and get to this point where you have to use this vacuum, you have to use forceps, because there are risks involved. So if there is severe fetal compromise, that is a contraindication. If the fetus is in a high station, so above the line of engagement, a fetus that is not engaged, you would not do this. If this is a situation of CPD, you would not do this. The risks are mainly tissue, soft tissue damage and nerve damage. So for the mom, soft tissue damage. For the fetus, soft tissue damage, facial nerve injury. There can be increased intracranial hemorrhage. There's an increased risk of intracranial hemorrhage. Okay, so the technique. Her bladder needs to be emptied. Cervix should be completely dilated, membranes ruptured, adequate anesthesia. So going back to the question, Palavina, that you had asked, it might depend on whether you use a local or you might use a, you might use a local, or you might use local infiltration, or you might use a pudendal block for these procedures. Okay, it just depends on how much anesthesia is needed. And the mom might need an episiotomy as well. Okay, so I'm not going to cover the classification of techniques. So you should just know that there are classifications, but I'm not going to cover them. It's a level of detail that you don't really need. All right, so again, we're talking about 2 types: forceps extraction, vacuum extraction. So forceps, these are what forceps look like. They are locking blades that are applied to the fetal head. So traction is applied during the contraction. So applied to the fetal head. So this, the fetus in this diagram is in what position? What position is this fetus?
OP.
Right occipital.
No, it's a LOA.
So I think we're in agreement that we're talking about the occiput.
Yeah, LOP.
LOP.
Okay, so is that occiput, so, and you're all telling me the occiput is posterior, which I agree with.
Mhm.
Is the occiput on the left or the right side of the mom's
On the
pelvis?
left. It
the
looks on the
right.
left. Oh, center and on the left, actually.
It's on the right.
Yeah,
On the
look.
left.
This,
Okay, so remember, you're looking at the mom. So your right is her left,
is that left, this one, LOP, right?
okay? So I want to make sure that those who are thinking it's right, are you seeing where it's left? It's
Yes.
your right, but it's her left.
Okay, I think I got it now.
Do you see it? So this is LOP,
Okay.
all right? So the occiput is on the left side, posterior pelvis. Okay. And actually, if you look at it, it's more of an actual OP than an LOP, which we'll talk about
Yes.
when we get to complications, because it's a little bit more centered. So this mom, you would anticipate this mom having what type of labor?
Painful. What do you mean? Painful? I mean, that is gonna break the sacrum or something?
What type of labor? We talked about this a little bit when we talked about position. Where's the occiput?
It's on the sacrum, on the coccyx.
And what else is in that general area?
Are you talking about
There
the?
we go, vagal nerve.
Go ahead, Andres.
Are you talking about the episiotomy?
No, I'm talking about the fetal head.
Okay.
The
I'm talking about the
vagal
fetal
nerve.
head. So I want you guys to look at the fetal head. Where is that occiput? What are the closest nerves to the occiput?
Is it the
The
vagus?
vagal nerve.
That occiput is closest to the sacrum.
Yeah.
So remember, sacral nerves are going to be pinched between the occiput and the sacrum. You have two hard surfaces. This mom is going to have back labor. She is going to feel a lot of pain at the back because of where the fetal head is and where the nerves are. So in terms of your nursing care, what is one thing you're going to do for this mom in terms, that's all I'm going to say, to make her more comfortable? What are you going to do?
Give her a massage. The sacrum area.
So remember, you're not just giving her a massage, you're applying what?
Pressure.
Pressure.
Counter pressure, right? So make sure that you review that. That was in the podcast, counter pressure, and how that works with the gate control theory. You guys learned that in anatomy, the gate control theory. So Rung, you're saying you would change her position. What position would you suggest putting her in? How would you reposition her?
God, just fucking talk, dude.
Lateral.
So wrong, left what?
Lateral.
Would you put her left? You could put her left. But if you put her left, you're putting her on this side.
On the right side probably is better.
You
Really?
could put her on the right side, and what other position could you put her in to relieve the pressure off of her?
Couldn't
On
you
her knees?
Can you put on the knee?
On all fours.
The knees?
Right, you could put her on a hands and knees position.
Knee,
I mean, she's
yeah.
not going to be able to stay like that for a very long time, but you relieve the pressure. Remember what I've said to you all the time, you got to use gravity in your favor. So hands and knees take some of that pressure off of those nerves. And also when you put her on her side, you position her in such a way with the support of pillows that her hips are actually a little bit higher. So she's on her side, but a little bit more almost going towards prone to take pressure off of those nerves. Okay. All right. So this diagram was not about position, but I want you to see how everything we've been talking about, it all comes together. And I need you to really, as I've been saying, you've got to start pulling all of those pieces together to think about, what will I do for this patient? What is she going to be experiencing? What do I anticipate her going through? How am I going to support her? Okay. All right. So these are the forceps being applied. Again, empty bladder, empty rectum. Traction is applied during the contraction. So as I mentioned, your concerns are soft tissue damage. As you can see, the baby on the left has bruising, facial bruising. Baby on the right has a hematoma to just below that, just below his or her, I think it's a boy, right eye. Okay. The other concern, facial nerve injury. This baby has facial paralysis 15 minutes after a forceps delivery. After a forceps delivery.
Professor.
So this is a major concern with forceps delivery. So tissue damage, it may be superficial, but as you can see, as you can see, this baby has, excuse me, a hematoma. In addition to the bruising, this baby just has the bruising. This baby has nerve damage.
Is it
This
temporary?
is one of the main reasons that many obstetricians do not like to use forceps, because of the risk of nerve damage. Now, whether or not this is going to be temporary or permanent remains to be seen. It will depend on the extent of it. Some of these babies, the nerve will repair, and some of them will have some lingering effects. So they might, the nerve might repair, but not fully. It might repair 100, it might self-heal like 95%. This is very, very concerning, because remember everything that this facial nerve does, everything that it innervates. All right.
Professor, then what, doctor is gonna get a lawsuit when this is happen?
Yes, absolutely. Absolutely. And this is why, as I said, why many of them do not like to use forceps. It's a risk. Now, sometimes you know, if it's an emergency where it needs to be used, or you're risking fetal oxygenation, what do? You know, so sometimes you have those situations, but there are risks. There are risks. Okay. All right.
Simona, probably it's a stupid question, but when the baby's engaged, it's impossible, like to perform a C-section, right? So either way, you have to pull it out, or you have any chance that you can pull it back, push it back? No.
No, once it's engaged, you're pretty much
You're done.
kind of locked in.
Okay.
Okay, so vacuum extraction. There are a variety of different types of vacuum. I'll show you a couple of them. So sometimes you will see the newborn will have what we call this first her first little bun, or his little bun there. This first chignon. All right. So one type of vacuum extraction, as you can see, some swelling here. We're going to talk about sulfohematomas and capots in a few minutes. So you can see right here that this was a vacuum extraction. This is going to be an important part of your assessment when you are taking care of these babies in the nursery. This is a different type of the kiwi. This is a different type. Oh, there's a picture that's coming up of a vacuum delivery, and I think it's using a kiwi. Okay, so you're always assessing for any type of bruising. Yeah, so this is a kiwi. So vaginal delivery, episiotomy, vacuum extraction. Yes.
So with this technique, with using these tools, you have to do an episiotomy, or you can prevent.
So that's what I said before. Yes, typically an episiotomy is performed. So there are two things you have to remember: the vaginal opening, whether or not an episiotomy is needed. Most of the time it is, and pain management. Right? Going back to Palavina's question earlier. So this mom, again, vaginal delivery, you can see the fetal head there. Vaginal delivery, episiotomy, vacuum extraction. Okay? All right. So again, observe the mother for trauma, soft tissue trauma. She may have a laceration. She could have an abrasion. So even if the episiotomy was done, she could still have a soft tissue laceration, okay? So make sure that a careful observation, a careful assessment is done, and any repair that needs to happen does happen. The baby needs to be carefully assessed for tissue trauma, soft tissue trauma, again, lacerations, abrasions, nerve trauma, facial nerve injury. And if there's any intracranial hemorrhage, that will be seen typically within the first few hours. Okay. All right. So that's operative vaginal birth. And that's it. Those are our procedures. That's everything on my list. Yep. So questions before we actually start talking about our newborn, finally. We gave birth to this baby like weeks ago, and somehow we haven't actually talked about the baby. All right. So